Let's talk about tourniquet for a minute. We've had some of this lecture a little bit before with tourniquet, and so some of this will be review will be good. Orthopedic surgeries obviously will use a ton of tourniquets. Most of the time, they're probably put on non-sterile before they prep and drape. There are some procedures they may put it on sterilely. Probably the most common one would be foot and ankle surgery. If they prep out the whole leg, then they'll put the tourniquet on after prep and drape and use a sterile tourniquet and wrap. Inflation of a tourniquet is used to, well, the tourniquet obviously is used to reduce blood loss during surgery, but cells distal to the tourniquet will shift to an anaerobic metabolism, and that happens within minutes. It doesn't take very long to start for those cells to turn into using a different type of metabolism. And obviously the byproducts of that is going to cause acidosis and can cause urinary issues as well. If you have a long tourniquet time, can cause some renal failure once you release that tourniquet down and dispose of all that basic body waste that's been metabolizing distal to that tourniquet. Once you let that free, it can cause some issues. And so there's some guidelines on using the tourniquet and how long we use it for, what's the pressure, what do we do. And so those are the things that you need to be aware of. And just know also that you guys, for the most part, and this is facility dependent, are the kind of the keepers of the tourniquet. You may be the ones that are asked to inflate or deflate or change the pressures, or they may ask you what the tourniquet time is. So whenever I have a tourniquet in the room, I always turn it towards me so I can always see it and easily answer questions related to the tourniquet. Inflation pressure for upper extremity is usually anywhere between 70 and 90 millimeters above systolic blood pressure, or 2 times over systolic blood pressure for lower extremity. Now just know that we're giving you these numbers that depending on what reference you use, they may be a little bit different, but just kind of know the range. It's going to be somewhere between 70 millimeters of mercury to 2 times over your systolic blood pressure. We've talked about tourniquets for use in a beer block. And we talked about double tourniquets as a reminder in the beer block to help the spread of the local anesthetic to go underneath the tourniquet and to prevent tourniquet pain, which is one of the biggest, or one of the, yeah, I'd say probably the biggest complications associated to an anesthesia provider is dealing with tourniquet pain and how we're going to deal with that and what that is. And we'll talk about that in a minute. This talks about beer block upper extremity, 300 millimeters mercury. I can honestly tell you, I usually only go to 250, but for reasons of boards and for Apex, go with the numbers that they give you. And same with lower extremity, that just kind of shows the difference in numbers that you may see. So tourniquet, you should have 2 layers of padding underneath it. So if you're doing a beer block and putting a tourniquet on yourself, just know that you should have 2 layers of padding. And when I say 2 layers, it doesn't have to be 2 different kinds of padding. Because if you're using whatever you're using, if you're using a cotton roll, just make sure there's at least 2 layers around the skin where the tourniquet's going to go. You have to have proper sizing of the tourniquet, and the reading is going to go more specific into this than I'm going to talk about. But just know that if there is proper sizing, you want to have at least 6 or 8 inches of Velcro attached. But if you go too long, if you have too long of a tourniquet, it can pinch the skin. And people, when you put tourniquets down, you'll see this all the time. They get these little lined bruises like where they've been pinched on the skin. So too big is not necessarily good. And too small, obviously, you risk of popping the tourniquet off in the middle of the case, which I've seen happen before as well. So you have to have appropriate sizing on your tourniquet when you're doing it. And you will see that every leg in orthopedic surgery comes in different shapes and sizes. You might have a skinny leg and you might have a leg that looks like a tree trunk out of Northern California. So different tourniquets, different sizes, you got to size them appropriately. Okay, so the tourniquet stresses the body in 2 ways. Obviously, restoring blood flow to the extremity produces a relative decrease in circulating blood volume and the products of cellular hypoxia, which we talked about, which can cause the acidosis. And anytime you deflate the tourniquet, you're going to see that restoring that blood flow will cause some hypotension, and it might even temporarily cause some desaturation. That's kind of normal and common. It's almost expected. And usually within most people, that'll reverse itself within the next couple of minutes. You can increase end-tidal CO2 because you got that CO2 buildup that's been happening with the metabolism below the tourniquet. You can get a decreased core body temperature because that extremity has been not having its blood circulating through there, so its temperature has gotten colder than the rest of the body. So now you're mixing in a pretty cold temp waste products or blood back into the system. It can decrease the core temperature. You get the decreased blood pressure just from basically you're opening up a whole other space to perfusion that hasn't been open for a while, and so it kind of empties the tank temporarily. You may get a decreased SAT or SpO2, like I mentioned, and yeah, obviously we'll get, if you're able to measure it, you'd see an acidosis that for most people corrects fairly quickly. Okay, tourniquet pain usually begins within 45 to 60 minutes. Now the thing with tourniquet pain to understand is that even under regional anesthesia, you can get effects of tourniquet pain. And the book goes more into it, talking about the C fibers and I think it was the delta fibers. Let me just pull that up in the reading real quick. So the C fibers is kind of the dull aching pain that you will get as opposed to more the tingling, it's the A delta fibers, more than the tingling pinprick type of feeling. So if you have a patient that is sedated and under some kind of regional anesthesia with a tourniquet on, they may start to complain of that dull achy pain, or they may get restless and start wiggling a little bit, and it's almost to the dot between 45 and 60 minutes. And the most common reason is this tourniquet pain. The local anesthetic affects the C fibers better initially, but as a local anesthetic starts absorbing off and wearing off, those C fibers kind of start coming back into effect or waking up a little bit more than the A delta, and so they get this dull achy pain. Once they get tourniquet pain, it can be sometimes difficult to deal with. For the most part, you can just work in a little, again, I'm just assuming that they're under a regional anesthesia and they're sedated. You can work in a little bit of fentanyl, that they'll tolerate maintaining their spontaneous ventilation. But if for any reason you think you're going to have a difficulty time or controlling tourniquet pain, and you still have a lot of case left to do, you may have to consider converting to general anesthesia at that point in time, whether it's putting an LMA in or intubating, depending on what position they're in, because tourniquet pain can be hard to deal with, and it's hard once it occurs. It's hard to recover from. The Apex and Nagelhout talked about pain as unresponsive to analgesics. I wouldn't necessarily say it's unresponsive, but you tend to have to start to give quite higher doses that if they're awake in spontaneous ventilation, you're going to hinder that and may have to ventilate them a little bit. So if you're going to, again, if you suspect that they're not going to tolerate a tourniquet at all during the procedure, you may want to consider general anesthesia from the get-go. Now, even under general anesthesia, you can see tourniquet pain. And the way it manifests itself under general anesthesia is hypertension and tachycardia, and maybe even if they're spontaneously ventilating under general anesthesia, you may see increased respiratory rate. And so you're still going to deal with tourniquet pain even though they're under general anesthesia. But at that point in time, you have probably a little more option in treating more aggressively with pain medicine, because if they become If they hypoventilate too much, then you can just turn your ventilator on. So it's a lot more, you can be a lot more aggressive in treating tourniquet pain. But again, it's almost always at 45 to 60 minutes, you'll start seeing tourniquet pain. Tourniquets should never be up longer than 2 hours. That's the max. And the surgeon will always be asking you, how long has the tourniquet been up? How long has the tourniquet been up? And typically you will set an alarm on the tourniquet to alarm at 60 minutes. Once it alarms at 60 minutes, you tell the surgeon that's 60 minutes on tourniquet. They'll usually tell you add another 20 minutes or add whatever. But a lot of times they'll just say, okay, thank you. Then you have to add some time to it. I typically will add 30 minutes of time every time the alarm goes off. You don't want to turn the alarm off and then next thing realize, oh, you're at 2.5 hours on your tourniquet and the alarm wasn't turned on. So you always want to change that setting to where it's going to remind you of where you're at. Because if you do hit 2 hours and they're still doing the case, they may take a break from the tourniquet by wrapping the leg up to minimize bleeding and putting the tourniquet down for 5 or 10 minutes, reperfusing the extremity, and then going back up on the tourniquet after they've reperfused it for a little bit. And so you want to maintain and know where you're at on the tourniquet. And so, and it's also something that we chart on our OR record, and our OR record should match, our anesthesia record should match the OR record on those times. So we typically chart inflation time and pressure and deflation time as well, and length of tourniquet time. There's all things you will chart. Okay, let me just cover.
Understand that they've got high circulating glucose levels, they just can't get it to the cell, right? You got all this stuff out there that the body needs, but you can't get it in because there's not enough insulin to do it. And then there's some diagnostic criteria. I'm going to ask you guys a question here shortly. I've got a case today with a patient who has a hemoglobin A1C, or last one was done last month, it's 7.5. She is a known type 2 diabetic, and she's on 3 oral hypoglycemics. And so I'm going to ask your opinion on what I should have told her last night when I did my pre-op. So there are some other parameters: fasting glucose greater than 126, random glucose greater than 200, 2-hour plasma, right? There's just some other diagnostic criteria. So we break this up into type 1 or type 2. Type 1 is usually there's low or no insulin production. Type 2, there's either a lower amount of insulin being produced and there's insulin resistance, right? So you've got it, but the body can't use it. They're resistant to it. And you know that the type 2 diabetics are usually, this is a older adult onset. There's usually some poor diet involved. There's usually obesity involved versus type 1, which is usually youth onset. It can be just something that's happened genomically. So that's kind of the difference between the two. Oh, and here's some stuff right here. So type 1, type 2. You can see that, the type 1 autoimmune, so that is the most common. Just some autoimmune issue that has then dinged them, and now they become a type 1 diabetic. Versus type 2, the most common is they're just getting obese. And like we've told you before, that is happening more and more. The patients overall, over the last 12, 13 years since I've been in this world, I think have definitely gotten just slowly getting bigger and bigger as we go. The other things on this chart, you can just kind of see the difference between what happens to a type 1 or type 2 diabetic, or how they look. Like the bottom, they're thin and wasting, versus the type 2 is the android obesity, which we had a discussion on when we did the obesity lecture. So we have diabetes mellitus, and you have the other side of that, which is the metabolic syndrome. Metabolic syndrome is something that you can see if you have at least 3 of the things on this list, and somebody can be diagnosed with metabolic syndrome. And these guys, when they go in, they can have some serious high blood sugars if they come into the ER. And there are, I'm not going to read to you what those are, but you can just see that, they're bigger, right? And a waist of greater than 40 inches for a man, greater than 35 inches for a woman. And then it looks at not only blood glucose, but also looks at triglycerides and HDLs and blood pressure. So it's a kind of a wider lens as we're looking to diagnose somebody with metabolic syndrome. So then we look at the 2 things: diabetic ketoacidosis and the hyperglycemic hyperosmolar state. You would compare these 2 things. Diabetic ketoacidosis is more common type 1 diabetics. Hyperglycemic which we're going to call this from now on HHS, because I want to keep saying that, more common with type 2 diabetics. So looking at what you see, which I think is the most important, in the diabetic ketoacidosis, their blood sugars are greater than 250. In the HHS, they are hyperglycemic up to greater than 600 milligrams per deciliter. So their blood sugars can be extremely high. And then if we look at treatment, it's very similar. So you volume resuscitate because they're going to be dry. You give insulin to get those blood sugars down. And then with the diabetic ketoacidosis, they talk about specifically potassium, because we're giving insulin, so it's driving potassium into the cell. The same thing I think is going to be happening with the HHS. It talks about correcting electrolytes. I'm going to say that on both of these, electrolytes are going to have to be corrected, but specifically on both is going to be potassium because of the insulin that we are giving. And we all know that if somebody is hyperkalemic, one of the treatments of that is to give insulin. So their blood sugars or their potassium levels could be low because we're driving that back. We're driving that into the cell. You will be dealing with diabetes mellitus more than any really other endocrine disorder. We see this all the time, either type 1 or type 2. And then there's just some other things. A glucose less than 100 is normal, above 126 is diabetic, and 125 is pre-diabetic. But this is the most common thing. So the meat and potatoes of this bad boy. So the things that we need to worry about as far as anesthetic management, right? A diabetic patient, it's not just a blood sugar issue. It is a systemic issue. Like, for example, I had an aunt back in the day. She was, maybe 15 years older than I was, and she died 20 plus years ago in her 30s. She was an insulin-dependent diabetic, so type 1, and she did not take care of herself, right? She'd look at what she would eat or what she wanted to eat, and it was anything she wanted. And she'd kind of like, I need 25 units. And she would go ahead and stab herself through her Levi's with 25 units of insulin. She was all over the board. By the time she died, which she died of a heart attack from massive coronary artery disease at 30-something years old, she was cross-eyed because the nerve in her optic nerve, or one of the muscles in her eyes became so weak that she went cross-eyed. So she had that. She was on peritoneal dialysis because her kidneys were failing. They were trying to get her worked up to go on hemodialysis. but she was too sick to do it. Complete shutdown at 30-something years old because she didn't take care of herself. So take-home message. These patients can have systemic disease and we may not know it. So we have to have, you have to do a very thorough history and physical, right? A 45-year-old who doesn't have any history of anything, no allergies to medicine, no medicines daily, no surgical, no medical history, that pre-op is going to go pretty quick. Versus your 45-year-old who is diabetic, the things that we need to be asking them in the pre-op history. So I am curious then, if you have that patient, 40 to 50-year-old, whomever, who's coming in for, you know, I don't care. Let's say it's, let's say they need to have back surgery. They need to have some fusions because they've got a poor back from some injury. What are some questions that you would want to ask your patient in that situation? And before, let me make this big so I can actually see your faces.
I want to know if they had any heart problems or history of heart problems or stents or anything like that.
Okay, so he tells you no. What else can you ask about dealing with the heart? So that's good, right? So that's kind of a general. Have you ever had any heart surgery or interventions? What else can you ask to be more specific?
I would ask about meds because sometimes they don't know why they're taking certain meds, like if they're taking gabapentin or if they're taking something for their heart.
Okay, good. Okay, I like that. What else? Cardiac specific.
I'd want to know their exercise tolerance.
Great, very good. Anything else?
Maybe
I would get, well, go ahead.
maybe an EKG.
Yeah, you know, depending upon what you found in the rest of your history, that could generate you wanting to get an EKG. So if they, you know, I would ask about shortness of breath, which goes along with Corey's talking about with exercise tolerance. I'd ask about chest pain at rest, ask about chest pain with activity. Just get into that kind of that cardiac thing that you all know to find out if they are going to be able to handle surgery, or if maybe they've got something going on and they've been dealing with it for so long they don't even realize that it's abnormal, right? Back to Corey's thing, can you walk 2 flights of stairs and not stop? Can you walk 2 blocks and not stop? If they're saying, yeah, no, I can walk about a flight, but then I've got to stop and catch my breath, they might think that's absolutely normal. So get specific, especially with these patients, because you want to make sure that you don't miss anything. Now, if you look at that autonomic nervous system dysfunction list, you can see all of the things that can happen with these patients when they're diabetic, right? They can actually have ischemia without having any pain, any chest pain, and there's a whole bunch of other stuff. The other one that is very interesting and that you need to keep an eye on is delayed gastric emptying. So they have an increased risk of aspiration. So I get very specific with that one. On my phone call last night, I got very specific with this lady and asked her all about GI stuff, right? Do you have any, start vague. Do you have any heartburn or indigestion? No. Okay. Do you have any burning in your chest before or after you eat a meal? When you on an empty stomach, what happens when you don't eat? What happens when you eat too much, right? Get specific, because if they're an aspiration risk, then you're going to want to go ahead and do an RSI and make sure that they are, that you are taking care of them so they don't aspirate in the OR. Airway, as usual, is a huge piece with this. And this is something that you should know, the prayer sign. Ask them to do this prayer sign, right? If they can't get their hands like this, then their joints have got a problem. Glycosylation, right? They cannot straighten out. So that is a problem. They're going to have a joint stiffness, not only in their hands, but a high chance of having it in their atlanto-occipital joint. So they could be a difficult intubation. So if you have somebody who you have them do your normal airway, right? You do your Malampati, you do your thyromental distance, you can do your upper lip bite test, whatever your favorite airway exams are. And if you're noticing when you're doing your thyromental distance, when you ask them to kind of extend up, if they're having a hard time doing that, pull out the old prayer sign test and see what they can do. Because this one is an indicator of difficult airway with a diabetic patient. Let's see, what else on this thing can I talk about? As far as fluids, right? If we are in a long case and we're getting large amounts of lactated ringers, right? That can easily cause your patients to become hyperglycemic. And so you're going to want to make sure that you are maybe using something a little bit different in the OR as far as fluid, maybe some normal saline. If your patient is extremely brittle, it's a longer case, then you're going to want to be checking blood sugars throughout the case to make sure that they don't get too low. If you read in Nagelhout now, which is a little bit of a contraindication, I think, on the next slide, or one of the slides coming up, Nagelhout says it's better that they're a little bit hyperglycemic than hypoglycemic. And in my opinion, I think that is how I would rather have my patient also. I think you're going to have much more or greater problems with a hypoglycemic patient, and it's more dangerous than you will if your patient is writing a little bit high. You can take care of that easier, I think, postoperatively than you can if they're hypoglycemic. It's just a little bit scarier, right? More problems can happen when they get low than when they get a little bit high. And when I say a little bit high, I mean a little bit high, not too high. Okay, oral hypoglycemics. It's interesting, this slide. My patient today is on metformin. She is on glibazide, and she is on, hold the phone. Please hold, please hold, please hold. She's also on Jardiance. So she's on 3 of them, and she takes them all in the morning. So before we move on, remembering going back to, I think it's first semester, I believe it's first semester, we talked about the pre-op history. With your oral hypoglycemics, and she takes them all in the morning, what would you tell her to do with them? Sprinklers are on, it's getting cold out here. What's that?
Don't you hold them? But if she was taking something like a long-acting insulin, you would just change the dose.
Okay, good.
Unless it's metformin, then you hold that 24 to 48 hours beforehand, right?
Which I didn't know that she was on that until last night when I called. So I had her hold, just like you guys are saying, I had her hold everything. So then I asked, all right, how often do you check your blood sugar? I got to go in the house. Hang on. Squeezing my butt off that. Since you guys made me get out of the sun. Okay. I asked her how often she checks her blood sugar. And she said, well, I don't really check it that often because the glucometer that I liked, I lost. And the one that I have now, I don't know how to make it work. So she has no idea what her sugars are. So I asked her to bring her stuff this morning so I can hopefully figure out how to use her stupid machine so I can see what she's running. And I also told her to bring her medicine with her. So after she wakes up from surgery, we can get those, at least one of them started again, depending on where she's at, but to get her back on what she's eating so we can get her back and regulated. A few key things as far as diabetes and anesthesia management, which is really the parts of this lecture and diabetes that I want to talk about. Like we mentioned, it could be difficult intubation because of that stiff joint syndrome. Discontinue the medications the night before. So my patient didn't take anything at night. She takes it in the morning. And as this says, no oral hypoglycemic medicines on the day of surgery. But once she starts eating again, I'm going to have her take it. So I had done all this before I had really looked at these last couple of slides on this lecture today. So I was kind of proud of myself that I actually was doing what I was going to be teaching you to do. She does not take insulin, but if your patients do take insulin, and this is where it gets a little bit sticky because depending on what you read, it's always a little bit different. And so for you, when you are studying for boards, I would stick with what Apex goes with. Don't read Nagelhout. Don't look at any other things. Go with what the latest review company is saying that's on the exam, so you can't get messed up because sometimes it's take half of this dose, and if it's within 48 hours, take a quarter. It bounces all over the place. So I don't really care for now what you memorize. You should realize that you're going to be changing the insulin requirements. So when you're in clinical, I would bounce that one off of your preceptor. Have some answers because they're going to ask you what you think, and then kind of go with what they say. And then as you're studying Apex, you'll be able to lock in what the latest thing is. But the one that is kind of a standard is if they're on any oral anti-diabetics that we do not give those. Most people will still do surgery up to a certain glucose. And like it says, there's nothing out there that says it has to be at X glucose, we're done. But most facilities have some kind of an upper limit trigger where if it's up to a certain point. So 300 to 400 is when most places are going to say, we're not going to do this today because there's something going on, right? If they're normally managed well and they're coming into the 300 to 400, then something's off, right? They could have an infection somewhere. Maybe they got a UTI. Who knows what's happening? If they're coming in and they're 300, 400, you find out that their hemoglobin A1C is 8.5, right? They're not regulated very well. If this is not an emergent surgery, then the anesthesia team, you and the surgeon may decide that for all of the reasons that can be a detriment to high blood sugars intra-op and post-op, you might want to go ahead and delay that. We should be checking sugars before and after, and maybe during the surgery, depending upon how brittle they are and how long the surgery is. So it's not unheard of to be doing hourly measurements during longer cases. You normally don't give glucose-containing fluids. And then make sure that when you are positioning your patient that you are being very careful because of the whole neuropathy issue that they might have, that they are in positions of comfort, hopefully before they go to sleep, if that's possible to do. But then you are padding everything and making sure that they don't have any problems with how you got them situated on the OR table. Like I mentioned, there are multiple things that can happen because your patient is hyperglycemic. And when I say, I told you before, I'd rather have them run a little bit high than low. And when I say a little bit high, I meant just a little bit high, because if they're way hyperglycemic, then you can have all these other issues with patients, right? They can be hypertensive, heart disease, renal failure, neuropathy. So we don't want to have your patients being too hyperglycemic. Decrease wound healing afterwards if they get extremely high. You've got neuro issues. So most places will have some kind of a protocol set in place, like this says if your patients are on an infusion pump also. A lot of the times if my patients run, they're well controlled with their pumps, I'll just let that keep going, because the newer pumps, as you know, the monitors are actually sensing what their blood sugars are on a almost minute by minute or 5 minute basis, depending on how new their pump is or their sensor. And then it's regulating how much insulin they're getting by what it is. So you don't even have to really worry about it anymore. Take home message to this is that, like I mentioned earlier, is that you do a thorough H&P. If you take a few extra minutes and do the H&P that you should, that could save you some grief intraoperatively and postoperatively with your diabetic patient. Okay, that was a chunk of.
Okay. Again, I'm not going to go through this top chart too much, but just know it's going to be kind of some opposites. And this is an extension, I think, of the previous chart: hypothyroid on the left side, hyperthyroid on the left side, and hypothyroid on the right. But some related conditions I want to talk about. One being thyroid storm. This is something that you guys need to understand, especially for boards. I remember having board questions on thyroid storm, and it's something I've never seen in my career or practice, but it's something that you could potentially see. And this is usually with patients that are hyperthyroid, and it can manifest itself usually within 6 to 18 hours postoperatively. And it's just a surge in thyroid activity that can occur from euthyroid patients when they have a stressful situation, which surgery obviously can be a stressor on the body. And you'll get all the effects that you get from being chronically hyperthyroid, but this is sudden onset of a thyroid storm. So you can get increased heart rate, you can get increased contractility, increased cardiac output, And for young, healthy patients, if they have a thyroid storm, it's probably, I mean, obviously it's going to be a concern, but it's probably not a big deal. But you can treat these with beta blockers. And as a side note, propanolol as a beta blocker will treat the cardiac effects of hyperthyroid, but it will also slow down or negate a lot of conversion from T4 to T3. And so propanolol is probably a drug of choice for a beta blocker in hypothyroid situations because of the effect it has on T4 and T3 as well. But having said that, thyroid storm in a patient that may have cardiac disease or cardiac ischemia, if you put them into a state with thyroid storm where you're tacking them out, you're increasing the workload of the heart, and it can be devastating to those patients that have no cardiac reserve for whatever reason. So that's what thyroid storm is. Myxedemic coma is kind of the opposite. It's severely hypo. I want to go back to thyroid storm. There's a couple of things that can mimic thyroid storm or what it can look like. And some of those things are like sepsis. So when you think of sepsis, people that are hyperthermic, increased cardiac output, heart rate, they've got that low SVR, and they're just hyperdynamic. That's kind of, so thyroid storm can look a lot like sepsis. It can also look like pheochromocytoma, which we're going to talk about later in this lecture, to where you've just got that huge catecholamine release in the body. It can look like cocaine or methamphetamine use. But the other thing it can also mimic or mask is MH. And so when you're and again, thyroid storm most commonly occurs 6 to 18 hours after postoperatively. There are some case studies of it occurring intraoperatively. And so if you potentially have a thyroid storm intraoperatively, you can see how that can create concern of, is this MH? Do we treat MH? Is it thyroid storm? You really don't know. You're probably gonna start treating the symptoms. Obviously, you'll probably treat for MH, even if it's not, because you don't know until you differentiate. But I just want you guys to understand it can mask some of those other things. All right, myxedemic coma, that's totally opposite. It's kind of the it's like the thyroid storm of the opposite end, where there's no thyroid. This occurs in end-stage hypothyroidism. Coma is a consequence, not a cause, of severe impaired function. Okay, so as an example, lap chole used to be probably a 7-8 inch incision on your right upper abdomen, and now you can do it. Most people do it with a 4 trocar type surgery, and that started in 1987. Typically, the big trocar goes into the belly button area. They'll have one right below the xiphoid process, and then they'll have 2 on the right side, sometimes 3. Every surgeon's a little bit different. And they'll utilize these trocars and place them so that they have the best access for whatever surgery they're doing. So with the chole on the right side, since it sits underneath the liver bed on that right side, they want to have most access to the right side. But then they'll stand on the left side, tilt them left side down and head up, so it kind of pushes the bowels out of the way of the liver bed. And then they'll use those right-sided trocar sites to reach up under the liver bed. And so it gives them great access. Again, lap chole trocar sites are going to be different than like an appendectomy versus a gynecological procedure, hysterectomy, depending on what procedure is, how many trocar sites you're going to have. There was a trocar, and I saw one surgeon use it that was a 4 different insertion site trocar that went through one insertion site umbilicus. So they put it in the umbilicus, but it kind of had 4 channels or tracks built into the trocar, and they would try to do all 4 instruments through that one trocar. He seemed to always struggle with it. It was kind of a cool concept, but I haven't seen it much. But just know there's always something out there that somebody's trying to innovate related to laparoscopic surgery. Okay, the one constant in the surgery is pneumoperitoneum. So we're going to talk about this significantly, why it's important, why we do it, how it helps. And obviously, probably the biggest thing is your abdominal cavity's got a lot of organs and bowel and not much space in there. And so the pneumoperitoneum creates space so that they can work their instruments around without trying to damage any of those organs or structures that are in the belly. Okay, 2 methods for creating a pneumoperitoneum. Now this needle that you see here is called oh my gosh, I'm brain farting, Verries. It's a Verries needle. So what they do is they'll pinch the umbilicus on both sides, they'll pull it up away, and then they'll insert this needle. It's kind of like a dual epidural needle. And so they want to be able to feel the structures as they go through it. It's also spring loaded, and you can kind of see it in the picture. There's a little red kind of stripe in there towards the top. So they'll put fluid, and you can kind of see that in the picture too, fluid into the end of the Verries needle. And it's almost like a hanging drop technique. As they push this needle down through into the abdominal cavity, as they get to peritoneum, the spring-loaded needle will kind of start to retract because the peritoneums can kind of be the last structure. It's a little tough to get through. And then as that spring releases, that's usually as they go through the peritoneum, so that red stripe will kind of show, and then it'll disappear as the spring releases. Then they'll drop fluid on there, or if they have it on there already, it's kind of got a little bit of a negative pressure in there, or it just, as they pull up and create negative pressure on the belly, that fluid should drop down into the abdominal cavity. And so that kind of gives them another indicator that they're probably where they want to be. Now, is it 100% proof? No, not always, but can be. So once they think they're in the peritoneal cavity, the abdominal cavity, they'll hook up the gas line right to this Verries needle, and they'll insufflate the pneumoperitoneum right off the bat before they put any trocars in. And hopefully some of these future slides will help you guys understand why they do it that way. So they fill up the pneumoperitoneum into the belly with this type of Verries needle. There's also a Hassan. So a Verries needle is closed, meaning the surgical site is closed, and it's the needle that gains access. The Hassan is a little bit different. It's an open type of trocar. So they will make an incision on the belly button with just the normal scalpel knife. They'll retract, go through the layers down to the peritoneum. They'll see the peritoneum, and they'll either cut it open and push the Hassan through and then suture it in, and then use that to inject the air in to create the pneumoperitoneum, or they'll use a bladed type of trocar, Hassan, and push it through the peritoneum, And these bladed trocars are spring-loaded as well. And once they feel that release of that pressure going through the peritoneum, the blades retract into the trocar so they don't accidentally cut bowel or any kind of structure as they pop through that peritoneum. So they're kind of cool, the blades. There's also bladeless. They also have a trocar, and it's not technically a Hassan, but the camera goes into the trocar, and then they hold the camera in the trocar, and as they advance it down through an incision site that they made, they can see the structures up on the TV as they go through it, and they can see the peritoneum, and then they can punch through the peritoneum as they do it. And so it's almost like a visualized through the camera type of trocar that allows them to see where they're at exactly as they're going through the layers. So those are kind of the differences in those types of trocars. And this is a picture of the Hassan method being used. Again, they make an incision. They'll usually add suture to the peritoneum. They'll pull suture up, and the Hassan trocar usually has a little round knobs that they twist the suture around that kind of holds it in place as they put the trocar in. So this is done through an open method. So the Hassan is open where the Varies is closed, and it's just a needle that's creating the pneumoperitoneum. And that's, again, another picture of the Varies needle. No incision, just being pushed through the skin. You can also have extraperitoneal gas insufflation. So if they don't quite get through the peritoneum and they start insufflating the belly because they think they're through it, and their airway pressures are alarming, but all that air has got to go somewhere. And so you may see sub-Q emphysema, mediastinum, or pneumo, I just realized that's spelled wrong, pneumopericardium. So you can get air around the heart, air up into especially if there's some kind of defect in the diaphragm or injury to the diaphragm, you can get collapsed lungs and have all those issues related to insufflating the belly. So potential results: pneumothorax, increased CO2, increased airway pressures. If you get through the diaphragm and get the pneumoperitoneum up in there, it's going to make your airway pressures even worse. And obviously, it's going to decrease your saturation because you're going to have a harder time ventilating these patients. Treatment: if you get any of those symptoms or signs, treatment, obviously the biggest one is going to be to evacuate the CO2 from the abdomen. So you're going to stop insufflation and release that pressure. If you need to, needle compression if it's a lung issue, or even possibly or potentially a chest tube. Okay, continued complications. Also, we have risk or issues with a venous air gas embolus. And so we're going to talk about that a little bit. Management of gas embolus. For some people, yes, it's a panic, and it's definitely something that we train for, that we may or may never see, but you have to be able and comfortable to be able to treat these patients because they can deteriorate quickly. Again, stop insufflation with venous gas embolism. CO2 is less dangerous than air because it's more soluble. So CO2, as it diffuses across membranes, can be we can breathe it off through the lungs. Most of the CO2 is going to deflate right out the trocars as we stop insufflation. And so that's going to be the biggest thing that's going to stop the embolus from going. But everything that has potentially crossed into the vascular system and become emboli is more soluble. And so that's a big reason why they use CO2. And we'll get a little more into that in a future slide. And then you're going to treat your symptoms. Severe, you may position patient to the right lateral and evacuate with a central line if you have access, or if you need to put one in, or evacuate CO2 if available with your central line. Signs and symptoms of the gas embolism: decreased CO2 because you'll get poor perfusion, desaturation, arrhythmias. So if you've got a normal healthy patient that's normal sinus rhythm and you're seeing a lot of these symptoms on top of arrhythmias, should be an indicator you need to start thinking about a potential embolism. For patients that have coronary artery disease or are at risk for coronary artery disease, may have some myocardial ischemia. And then you can have hypotension and increased CVP because of the right side heart pressures on the heart from the embolism into the lungs. Shock may occur from cardiovascular collapse or depression. Treat with fluids, vasoconstrictors, and inotropes if you need to. This is very similar to neuro, and we'll probably get into this venous air embolism again in neuro cases. And so this will be a review. This is another picture of what I was talking about, adhesions of the bowel on the anterior wall. So you may have that pneumoperitoneum, and as you go to insert that trocar, there still can be bowel that's adhesed up in there. And that's really common if they've had abdominal procedures before. If they've got a virgin belly, never been operated on before, it's probably less likely, but can still happen, especially in females that have had some sexually transmitted diseases that's created a lot of pelvic inflammatory disease. They can get a lot of adhesions as well. This is a picture of a hole in the diaphragm. And so, and if that was just a defect or if that was caused from a trocar, I don't know, but you can see where that caused a pneumomediastinum. It's not fun because it's going to create some major ventilatory issues. Sub-Q emphysema, that's what this picture is kind of showing. They'll get the crackly skin and as you push on it. And so you may see that. Okay, ideal gas for pneumoperitoneum, just like we talked about CO2. The biggest reason they use that is because it's soluble and we can, very soluble, and we can manage it through ventilation a lot of times with breathing off our CO2 through that solubility. Normally you'll run your CO2 4 to 6 liters per minute. Pressure, they'll set their machine up to run off of pressure. So just like we kind of think about our ventilator, when we pressure control our ventilator, it's going to give the volume that's allowed with the max pressure that we kind of dial in. So this is kind of the same thing. Pressure is going to be calculated or sensed by this machine, and it'll give as much volume to maintain or keep under a certain pressure. Normal pressure in the peritoneal cavity is 0 to 7. It's the most frequent used gas, CO2. It's non-combustible, it's colorless, and it's non-toxic. The other big advantage is you can use lasers because of it being non-combustible. You can use lasers inside the peritoneal cavity with that pneumoperitoneum. And then again, it's highly soluble.
Hey, Ted.
Yeah.
Sorry, I might have missed this. So did you say that this gas is controlled with another machine, or do we do it from our?
You don't do it at all.
We don't do it at all.
Nope.
Okay.
The surgeons will, and the circulating nurse will control all that machinery.
Okay.
But you guys need to be aware of it and how it works. Okay, physiology effects of pneumoperitoneum, and we're going to talk about several physiological effects. We're going to start off on cardiovascular physiological effects. So initially, as you start this pneumoperitoneum, you may get an increase in blood pressure, an increase in circulation volume. And so what happens is that pressure starts to build up in the abdominal cavity. It starts kind of pushing blood out of all the vasculature in that area. It kind of pushes it further into the system. It kind of be like raising people's legs up when they pass out or when they're hypotensive. You're trying to get gravity to push that blood into their system or their central system. So initially, you may get that just from fluid shifts of blood because of the pressure. Now, as that pressure builds up, then you're going to start getting increased abdominal pressure that's going to create IVC compression and decrease your preload. And so you'll get decreased blood pressure and decreased venous return, and especially if you throw positioning on top of all this. For instance, in hysterectomies, for some surgeons, not only are they putting them in lithotomy, which you guys kind of know what that does to your FRC and your intra-abdominal pressures and cavities and pushing on your lungs. Not only do they do that, but then they insufflate the belly with a pneumoperitoneum, and then they want them dumped onto their head. And so they've got this head down pressure now that's just compounding, all three of those things, compounding on all these increased pressures. So you can have blood pressure issues. This is why you get fluid shifts, and in prolonged cases, you'll get the swelling of the eyes, the face. And if you get swelling of the eyes and the face, you almost have to assume that you probably have some airway swelling. And so you've got to take in some considerations on what you're going to do for extubation because of that. And we've talked about checking a leak around a tube with a potential airway pressure, and that's something you would want to consider. Oh, this is the other reason for that case that I was talking about. We put in as big of an ET tube as we can, because when you start talking R to the fourth power radius and how much effect tube size can have on ventilation and moving air, even going from a 7.5 to an 8 tube, or even an 8 to a 9 tube, if you can do it, will make a huge difference on you being able to ventilate these patients. And so big tubes always typically a bigger size than we'd normally do on just normal cases. The other thing that you will see, and I will suspect that almost all of you guys at some point in time will see this because it's more common than not, is as you stretch the peritoneum, the theory is of a vagal stretch stimulation, you'll get severe bradycardia. Now, this usually occurs at the beginning when they're first insulating the patient. You'll get that stretch. As their body compensates for it over time, it doesn't really happen in the middle of a case. Not saying that it couldn't, but it usually doesn't. It's usually the initial pneumoperitoneum stretch, you'll get vagal stimulation. And it can be significant on some people. You'll have young, healthy girls getting a hysterectomy, and all of a sudden their heart rate goes from 80 to 20. And as you watch those pauses go across the screen, and sometimes they'll get 2 or 3 beats, and then they'll have this huge pause. You're like, holy crap, are they gonna go asystolic, or are they gonna break through here? And so it's more common than not that you'll see this, and it'll make you shart your pants a little bit. But first thing you want to do is obviously turn off the gas. So you got to communicate with the surgeon. Hey, severe bradycardia, I need you guys to turn off the gas. And they're really good at disconnecting and pushing on the belly and getting that pressure off the vagus nerve. But you also have to treat them with, depending how severe, whether you go with glycopyrrolate. If you just see it trending, a lot of us probably will just use glycopyrrolate. But if it drops right into severe bradycardia or those huge pauses, I'll go right to atropine and give them some atropine. And once that kicks in, then you're fine to start again and create the pneumoperitoneum. And with those medicines on board, you usually don't have an issue with that vagal stimulation. But it's more common than not, and it'll freak you out when you see it. Okay, more physiological effects. We're going to talk about multiple things here. Hemodynamic changes associated with pneumoperitoneum and pulmonary function associated with it. Okay, pulmonary function, you get a decreased FRC, increased airway resistance, reduced pulmonary compliance, and all of that can give you O2 desaturation. We talked about the facial airway edema, and you can also get hypercapnia. On top of having a hard time ventilating and maybe even hypoventilating, you've got the CO2 infusion that'll increase your CO2 level and create the hypercapnia. So what are some things you can do to counteract this? Some people use pressure ventilation. You want to maintain minute ventilation, but you can't tolerate the increased airway pressures by changing tidal volume, so you'll get increased respiratory rate to increase your minute ventilation. You can change your IE ratios to try to adjust your pressures that it's taking to utilize to move the air in and out of the lungs. So multiple things that you can do, and one thing may not work for everybody, so you just have to know that you might have to try multiple different regimes to try to get a good ventilation. And if you can't, you've got to communicate with your surgeon that, hey, I cannot ventilate this patient, and hopefully by then you'll be able to reduce some of the Trendelenburg positioning, or they can put their legs down a little bit if they're in lithotomy to take some pressure off their belly. We had one surgeon, or two, for instance, we have 2 OBGYN surgeons I used to work with. One of them wanted the bed in as steep as Trendelenburg as it can go, no matter if the patient's 300 pounds and you're having a hard time ventilate. She felt like if she couldn't have that patient in that position, she couldn't do the surgery. And so it was a struggle sometimes. And then on the flip side, totally opposite, we have another surgeon who will create the pneumoperitoneum and put all his trocars in, and then as he positions the patient, he's watching on the camera what effect he's having in position change inside the belly. And once he gets steep enough Trendelenburg that everything's kind of pushing out of the way of the uterus, all the ballast starting to fall out of the cul-de-sac where the uterus sits, he's like, stop there. That's all the Trendelenburg I need. Gravity's pulled everything out. I can see everything I need. And you may be only at 20 degrees compared to steep 32 degrees with that other surgeon, and it makes a huge difference. And we try to have conversation with her to tell her, you know what, the visualization between 24 degrees on this patient and 30 degrees didn't change at all. But the thing that did change is the complications associated with that steep Trendelenburg. And so you have to have a good open communication with your surgeon, and hopefully you'll win the battle. And sometimes you might, and sometimes you might not. Other issues associated with pneumoperitoneum, other effects. Obviously, you could have abdominal compartment syndrome from all that pressure, and you can get fluid shifts and swelling that can cause hypotension and hypoperfusion. You can also have increased ICP and cerebral edema, just like with your eyes swelling and your airway swelling. And some people, when I say their eyes swell, their conjunctiva will really swell, and it almost swell to a point where it's sticking out from underneath their eyelids, and it'll kind of freak you out. It'll look like something out of some kind of zombie movie. So they can get significant. If they've got enough swelling going on from position change and airway pressure change and pneumoperitoneum pressure changes, you potentially could have some cerebral edema, especially on some long cases associated with this type of positioning. And then obviously you can have regurgitation of gastric content, even if you have a compliant sphincter. It's just intense pressure on that sphincter, and if there's stuff in that stomach, it potentially could work its way through, and you could have regurgitation. The good thing is a lot of times you're in that steep Trendelenburg, it usually will come out the mouth as opposed to going back up into the lungs. Plus you have an ET tube in with a balloon that's going to protect it. But if you see regurgitant, you're going to want to make sure you suck them out really well. And that would probably be an automatic indicator for awake intubation as well, or awake extubation. Types of surgeries.